60 minutes, we are going to see what new vitamin D can give us in perinatal medicine. First, we will look at the present scenario of vitamin D in perinatal medicine. Then we will come to the molecular studies done in animal models. Getting clues from here, we will shift to human studies which give direct practical tips. And then the most important section of my talk, vitamin D versus antenatal steroids in preterm delivery, dose, and finally the transformational power of this talk. We all know that vitamin D deficiency, friends, is now a global phenomenon. But I wanted to know what happens to these low levels in pregnancy. Zhang in 2014 stated that it further lowers down in last trimester of pregnancy. Now there are empty number of studies saying that there is low vitamin D level in pregnancy, in cord blood, as well as in neonate and especially preterms. Working exclusively for vitamin D, I am often asked, how can you put vitamin D in each and every condition? The answer is, what if the receptors are present in almost all the organs? And now, to enrich the list, Evans in 2004 demonstrated vitamin D receptors even in placenta, along with its conversion enzyme. He further worked on it and said that in lower vitamin D states, there is reduced development of placenta along with reduced weight, which can be a cause for preterm birth. Very important point. Let us look at the transplacental transfer of vitamin D. It majorly occurs in last trimester, and poor preterms are deprived of this benefit and getting severely deficient. Now coming to one of the very delicate organ of preterm, lung. Yes, fetal lung. Let us see from square one. 40 weeks of pregnancy, different parts of lung are formed at different times. Alveoli in the last weeks, spilling over even after birth, and surfactant from 24 weeks to 34 weeks. Alveolus lined by surfactant, and the most important cell for all of us, type 2 pneumocytes or alveolar type 2 cell producing surfactant. Now we come to the molecular studies done in animal models one by one and find what can they give us in our human studies. Gwen in 1987 projected fetal lung as one of the targets for vitamin D action. He also demonstrated vitamin D receptors in type 2 pneumocytes and also added that vitamin D has a maturational effect on type 2 pneumocytes. Each word, friends, is very, very important. Marin in 1990 also demonstrated maturational changes in type 2 pneumocytes when vitamin D was added, and he also said there is enhanced synthesis and release of surfactant. A very important sentence. Edelson in 1993 beautifully stated that by vitamin D there is enhanced synthesis of DNA in type 2 pneumocytes. Brun, Gaultier and Halloran, friends, worked on the same subject and endorsed it. Shakurai in 2009 presented his prestigious paper titled an essential physiological role of vitamin D in perinatal pulmonary maturation. The title itself describes everything, and he stated that there is an increased alveolar count, increased septal thickness, which will give strength to the fetal lung. And he also stated that vitamin D inhibits apoptosis in type 2 pneumocytes. Zosky in 2011 said that in vitamin D deficiency, there is altered lung structure as well as function, demonstrating smaller lung volume and higher airway resistance. Mandel in 2014, friends conducted a very interesting experiment. He injected endotoxin intraperitoneally, of course in animal models, in one group and with vitamin D in another, and showed that there is an increased survival and better oxygenation in vitamin D supplemented group, which goes to say that vitamin D also has a protective role on fetal lung and type 2 cells, and concluded that early vitamin D supplementation can reduce the risk of acute respiratory distress. Yet in 2014, just 2 years back, also demonstrated increased surfactant production and increased alveolar count. Likeden, 2016, that is this year only, said that in vitamin D deficiency, there is decreased oxygenation, survival time, decreased lung weight as well as birth weight. Friends, getting clues from these molecular studies done in animal models, we walk on to human studies. Rehant in 2002 coined vitamin D as significant stimulator of synthesis of surfactant in human type 2 pneumocytes. Fokela in 2005 demonstrated vitamin D receptors in human type 2 isolates from fetal lung. Atasevin from Turkey in 2013 did an observational cohort study in preterms and found that vitamin D could be a risk factor for RDS. The supplemented group had a lower incidence, almost 3.34 times of RDS than non-supplemented group. Wagner, a very popular name in vitamin D researchers. He published his prestigious paper in 2013 and 15 and gave a very important statement that there will be a lower risk of preterm birth with mothers who have higher level of vitamin D. Setin Kaya from Turkey in 2015, that is just 1 year back, studied in 100 preterms, all with RDS. 31 of them developed BPD. All of them, all 31, had vitamin D levels below 10. And it was lower as compared to rest of the group, and the difference was statistically significant. And this section is for ventilator enthusiasts. Backstrom in 1999 worked in 39 preterms and supplemented them with around 1,000 units of vitamin D and showed a reduced need for assisted ventilation as well as reduced need for oxygen supplementation, and both the points were statistically significant. Mulder and Vendatoli showed that there will be decreased need of mechanical ventilation in group with vitamin D supplementation. On studied preterms with very low vitamin D levels, that is below 12, and said that there was an increased oxygen requirement, resuscitation as well as assisted ventilation, and the difference was all statistically significant. I wanted to know what happens to these neonates when they cross their infancy period. Hat from Australia in 2015 showed that there is an impaired lung development around 6 years in children born to mothers with low vitamin D levels. Shores from Denmark in 2016, that is this year only, said that there is a significant reduction in respiratory tract infection in first 3 years if mothers were supplemented with vitamin D during pregnancy. As I was preparing for this talk, friends, I was told to take only evidence-based things like antenatal steroids in preterm delivery. But you know what happens? Researchers always try to cross the boundary and want to find what is new and useful, which amuses them and they can offer to the society. And see what I have found. Two groups of cells, type 2 pneumocytes. To one, vitamin D was added, to another, steroid was added. Both produced surfactant more than without supplementation, but surfactant production was more in vitamin D supplemented group. Surfactant release from pneumocyte cell into the alveolus was significantly more with vitamin D group. Friends, working since last 7 years with vitamin D, I can see vitamin D can replace many drugs in our practice. One of them is steroids. I've seen its effect in asthma, allergic rhinitis, skin disorders, and nephrotic syndrome. But why do I want to replace steroids with vitamin D? Because when I give vitamin D, the system strengthens. While with steroids, it goes down. All other systems of the body are strengthened by vitamin D, while with steroids, they are weakened. Vitamin D is a natural physiological need of human body, while steroids, most of the time, no. The only upper hand steroid has on vitamin D is it is well worked up, and vitamin D is in its neonatal state, has to cross a long path to get acceptance. Dose, the most difficult question to answer, but I want to say we will play it safe, half from nature and half from supplements. Hollis from US in 2011 said anything below 4,000 will be an insufficient dose in pregnancy, and even 4,000 gives just 32 units. Two other studies endorse this fact. But is 32 normal? To me, 80 to 150 nanogram per ml is normal, and you will get all the references for this statement in my website named Vitamin D for All. Coming to dose in neonates, McCarthy supplemented 400 units to preterms with levels below 20. On 18th day, the levels were 20. On 104th day, around 90% children went up above 20, which goes to say that 400 units is an insufficient dose. Backstrom supplemented around 1,000 units to preterms, and he found a rise from 12 nanograms to almost 27 in just 6 weeks. Lastly, coming to the transformational power of this talk. Friends, if used in a planned way, take my words in writing, it has power to replace and reduce the use of surfactant in our practice, which will bring down the cost, complications, and many things. And it will also decrease the need for assisted ventilation. Friends, in our practice, we have seen many molecules come and many molecules go. They are washed away with the wave of time. But vitamin D is here to stay because it is the truth of human life. And thank you for that patient, curious listening.